This chapter deals with neurosurgical approaches to major depressive disorder. Major depressive disorder is diagnosed based on the DSM-5. There must be the presence of at least 5 of these 9 symptoms within a 2-week period or episode. At least one of the symptoms must be depressed mood and loss of interest/pleasure. In other words, anhedonia. Depression is quantified using standardized validated scores. The most common being the Hamilton Depression Rating Scale, or the HAM-D, or the Montgomery-Åsberg Depression Rating Scale. Response is generally defined as an improvement of 50% on one of these scores, although some studies use 40% as a cutoff for response. The key thing is that this needs to be defined in advance. Remission also is typically defined by a specific score. So a HAM-D score less than 8 or a Montgomery score less than 7 is generally associated with remission. In other words, there's no signs of depression. It's just sort of whatever you would find in an average person. Now, these 50% cutoffs, they're quite important because they sort of determine whether or not a study is deemed successful or not. And to some extent, 50% seems like an arbitrary choice. However, there have been studies that have linked percentage improvement on these scales to how much obvious clinical improvement there is within a patient. And generally speaking, a 50% improvement equates to approximately what a clinician would estimate to be a significant or a substantial improvement. So there is some reality to these scores, although there is an arbitrary aspect to them. Surgery for major depressive disorder is reserved for patients who have severe treatment-resistant illness. So in other words, most individuals who develop a major depressive episode improve with medications or psychotherapy or simply just time. However, there's probably about up to a third of patients who do not improve with those treatments, and some of them go on to have severe treatment-resistant illness, and those are the patients we're talking about here. And each study that you'll see for major depressive disorder in terms of neurosurgery might have slightly different inclusion criteria, but in general, most studies require that patients have to have moderate to severe symptoms based on the scales that I mentioned in the previous slide. They also have to meet certain criteria for refractoriness. So in other words, they have to have been tried on multiple antidepressant medications, as well as some augmentation or sort of second-line agents. They also have to have tried psychotherapies, such as cognitive behavioral therapy, and some centers even insist on patients having tried ECT, electroconvulsive therapy, as well. And so based on all of this, you can see it's very important to have at least one, but sometimes a team of psychiatrists involved in these studies as well to help determine these, and with each patient to help determine if the patient has truly tried all other treatment options and is indeed refractory to those. Now, surgery for major depression can be categorized as lesional or deep brain stimulation. There's different ways you could categorize it, but here's one approach. So under lesional, there are standard procedures that are performed at centers all around the world, such as cingulotomy, capsulotomy, subcaudate tractotomy, or limbic leucotomy. Deep brain stimulation can be performed using different targets within the brain. And each target, of course, has different scientific rationale to support it and different levels of evidence to support it. So some of the more common targets, and there are others beyond this list, but these are probably the most common. The subcallosal cingulate, the nucleus accumbens, and notice we have a slash for ventral striatum and ventral capsule. Not going to get into it that much in this slideshow, but these three targets are very similar. To some extent, the ventral striatum is synonymous with the nucleus accumbens, and very nearby to this target is the ventral capsule. So sort of treating those as all the same, but there are some subtle differences. Also, the inferior thalamic peduncle, or the habenula, and finally, the medial forebrain bundle. And although there's many different targets, there are some other similarities between them. Many of these targets are actually part of the same or overlapping neurocircuits within the brain that have been linked with depressive symptoms or related comorbid symptoms such as anxiety. There are other modalities and features of both of these categories, lesional and deep brain stimulation, that are worth elaborating on slightly. So lesional neurosurgery can be performed with different techniques. The first one is radiofrequency ablation, RF ablation, it's commonly referred to. And this involves an actual open surgical procedure. There's an incision on the scalp, 2 burr holes are drilled, one on the right, one on the left, and an electrode is placed stereotactically or inserted stereotactically into the brain, into the target. That electrode, the tip of it, is heated up, usually to about 85 degrees, and left at that temperature for approximately a minute to cause a lesion. Sometimes multiple lesions on each side are made. So that's RF ablation. Next, stereotactic radiosurgery. So it's still performed stereotactically, but here, different approaches to using radiation to make a lesion can be made. So that's targeted radiation. One of the most common is probably the gamma knife radiosurgery, but there are other approaches as well. With that approach, generally it takes a few months for the lesion to actually appear on imaging due to the mechanism of action of radiation. And finally, more recently, magnetic resonance guided focused ultrasound is also a stereotactic approach. It's also done without a skin incision, sort of like radiosurgery. The difference is this uses sound waves or ultrasound to create the lesion. So there's not actually any radiation exposure, and the lesion is created almost right away. There are other limitations to this procedure as well. So all three of these have a role in psychiatric surgery still. In terms of deep brain stimulation, there's sort of a few features or modalities that get discussed. Obviously, there's many different types of deep brain stimulators made by different companies. There's different features to consider. One option is something called directional stimulation. So certain deep brain stimulation systems allow for the clinician to program not only the intensity of stimulation and other settings, they can also direct the stimulation. In other words, point it anteriorly, point it posteriorly, and customize it in other ways. There's also now rechargeable batteries being used in deep brain stimulation, and this may have been touched on elsewhere, but this is becoming an important consideration. And finally, closed-loop stimulation. And in this field of depression, it's largely still under development. It's not really something that's been well established yet, but it is being studied extensively. And the concept here is the deep brain stimulator could actually record and sense neural activity associated with depression and turn on or adjust its stimulation level in accordance to those readings or neural biomarkers. Now we're going to briefly go over some key publications in this field. So these are sort of the highlights from Table 2 of this chapter. So firstly, a critical article came out in 2005, published by the Toronto group, demonstrating the clinical feasibility of performing subcallosal cingulate deep brain stimulation in depression. So the target, the subcallosal cingulate, and others refer to this as the subgenual cingulate. They're synonymous. They're just different ways of describing this region of the brain. This target was chosen based on extensive work much of which was performed in the late 1990s and early 2000s, which identified this region as a critical node in the depression circuitry. So in this study here, you can see 6 patients received deep brain stimulation to this region of the brain, and 4 out of 6 achieved a stable, significant response by 6 months. A key aspect of this study was the use of PET imaging, or positron emission tomography, and this revealed that this region, the subcallosal cingulate, which is generally hyperactive in depression and also in healthy controls who are thinking of sad memories. So it revealed that this region, in those patients who responded at 6 months, this region became down-regulated or hypoactive. The same group extended or expanded this work, then reporting a 20-patient series, again with similarly impressive clinical results. You can see here, especially on the second graph, you can see that some patients were even achieving remission over time. You can also see that the response began to appear even as early as 1 month, but importantly, the response gradually improved over time, perhaps even continued improving to 6 or 7 months, and other studies since then have suggested the response continues to improve even beyond that. Another key thing here was, this is now 20 patients, so this lent a little bit more credibility to this field, and the longer term outcomes suggested that these improvements may in fact be stable or persistent. So those past 2 studies were looking at the subcallosal cingulate as a target. As I mentioned, other targets have been considered. So described here is the ventral striatum, or the nucleus accumbens target. So Malone et al. Published a 15-patient series, again in 2008, this time targeting the nucleus accumbens. You can see it here. And that image showing the electrodes, the coronal image on the right showing the electrodes in the target, that image makes the electrodes appear a little bit larger than they really are, and that's due to MRI artifact. This target, as opposed to the subcallosal cingulate, was chosen for a variety of reasons. There's multiple reasons why this was chosen, but one of which was that the nucleus accumbens, also known as the ventral striatum, had been stimulated in patients with OCD previously, and those patients improved. And quite notably, those patients who had depression, their depression improved with this stimulation. So that was one of the things that identified this as a possible target in depression as well. So using an almost identical target, Guranic et al. Published similar results in 2010. And again, you can see the clinical results are very impressive. Again, patients continued to improve probably up to about 12 months or so. Their improvement was quite stable as well. So the targets that have been described so far, the subcallosal cingulate and the ventral striatum, those are targets that are identified on an MRI. You can actually see those targets. Now, this target described here is the medial forebrain bundle. And the interesting thing about this target is it's not visible on a conventional MRI. It's only visible using something called diffusion tensor imaging or other forms of tractography. You can see the image there revealing this tract. And this tract is kind of difficult to describe in humans. It's much more obvious in rodents. But essentially, this is an ascending, largely dopaminergic tract from the brainstem ascending to the ventral striatum, so projecting dopamine into the ventral striatum and also projecting into the prefrontal cortex. And they're specifically going after the superolateral branch of the medial forebrain bundle. So Thomas Schlepfer and Volker Koenen in Germany published this series in 2013, targeting this region of the brain. And the unique finding here, compared to some of the other open label series, is the rapidity of onset. So if you look at the graph, you can see they gave it a nice lead up to showing how stable each of these patients' depressive symptoms were. And they found, not on a matter of months, but on a matter of weeks, patients made a dramatic improvement. So some patients were significantly improved, immediately upon turning on stimulation, or within 1 or 2 weeks. And they reported at least 50% of the patients making a significant improvement, even higher than 50%. You can see the red line on that graph showing the 50% improvement or response rate. And again, they reported that clinical improvements were quite stable. So this was quite a revolutionary thing in the field as well. A new target being identified through a novel neuroimaging technique. So following these and other open label studies reporting extremely favorable response rates, 2 large industry-sponsored randomized controlled trials failed to detect a difference between active and sham stimulation. So this really rocked the field. This was a substantial issue, and I'm going to briefly describe those 2 large industry-sponsored trials now. The first one to be published by Doherty et al. In 2015 used the ventral capsule ventral striatum, so referred to as VCVS, as the target. This trial was terminated early after just 29 patients, when essentially no difference was detected between patients undergoing sham and those undergoing active stimulation. The primary outcome was the Montgomery Depression Score at 4 months. Patients were implanted with electrodes. The electrodes were turned on in half of the patients and not turned on in the other half. And the primary outcome was recorded at 4 months. And as you can see, the active stimulation, so 15 patients, versus the sham stimulation, 14 patients, there was really no difference in the depression improvement. And if you look at both groups, there was some improvement, but it wasn't very substantial in either group. So at this interim analysis, it was found that it was calculated that the number of patients they would need to treat in order to detect any significant difference was unfeasibly high. So the trial was stopped early. Another trial called the Broaden study. This one used the subcallosal cingulate. So again, these are 2 of the 3 targets I've talked about so far. So the Broaden study was also terminated early. This one, though, 90 patients were treated. Like the previous study, this was a multi-center study, and it had a very similar approach. Instead of 4 months, it was a 6-month primary outcome collection. So sham stimulation or active stimulation for 6 months, and then the primary outcome, and this time it was it was also the Montgomery score was collected. And once again, there was no significant difference detected between sham and active stimulation, and the number of patients needed to treat in order to detect that difference was predicted to be very high. So the trial was stopped early. So this was quite odd. It was a bit of a head scratcher for many in the field, because after all of these open label studies that had been very promising and had showed improvements within just a few months, these 2 seemingly well-designed large studies were in fact negative. So why could this be? It caused a lot of introspection within the field, trying to understand explanations for what could be going on. Some of the possible hypotheses that arose, probably one of the most popular ones, was that there's in fact a very strong placebo effect that occurs in the sham stimulation group, and recording a primary outcome at 4 or 6 months may not be long enough to dissociate placebo and treatment effects. Right? So the placebo effect is described in all fields and is a known effect, and there's nothing wrong with the placebo effect, but it's something to understand. And it's known that if an intervention is more invasive, it tends to harness a stronger placebo effect. So potentially, patients with sham stimulation were still benefiting from a placebo effect at the 4 or 6 month outcome time point, and therefore that's why those trials were negative. In both of those trials, after those time points, the trials were converted to open label stimulation, and patients went on to continue to improve. So it's very difficult to confirm or deny this hypothesis. Another possible issue here is that deep brain stimulation involves more than just the surgery. It involves extensive follow-up and stimulation optimization, where the intensity and other settings of the stimulation are adjusted or fine-tuned, usually by a psychiatrist who knows the patient well. This adjustment is done based on side effects, but also based on clinical efficacy. And everyone does it a little bit differently, but in some individuals, this process of optimization can take months or even a year. And so potentially these randomized control trials didn't give adequate amount of time for this type of optimization to be performed. So based on these two studies, these two large industry-sponsored RCTs published in 2015 and 2017, there have been ongoing and planned studies in depression that will utilize novel trial designs, given the complexity of the disease and also given the complexity of the treatment. And quite excitingly, one study was actually published in 2016, so before the Broaden study was formally published, although the 2015 study had already been published. But in 2016, a group in the Netherlands, led by Dr. Denny's as well as Bergfield, published a study using a novel or very interesting study design, and it's sort of illustrated with this figure here. So essentially, patients received stimulation to the VCVS, and they underwent 52 weeks, approximately 52 weeks of open label stimulation. And during that time, they saw psychiatrists regularly and had optimization of their stimulation. So adjustments to make sure everything was just right and to maximize the clinical response. Once patients were stable with their stimulation levels and had reached whatever level of improvement they seemed to be able to reach, then they underwent randomization, and they received either active stimulation or sham stimulation, and then a crossover where they received the opposite. So this occurred for 12 weeks. So it was 6 weeks of on versus 6 weeks of off. And the primary outcome was essentially the response rate at 12 months after the open label stimulation. So it wasn't a primary RCT study, but they also looked at the difference between the active and the sham groups during the crossover study. So this study not only found that 10 out of the 25 patients they treated were responders at 12 months, which is a reasonable percentage in such a refractory population. They also found during the crossover section of the study that there was patients receiving active stimulation had a significantly improved Hamilton Depression Score compared with the sham group. So this trial really opened the door in the field to exploring novel trial designs and considering that in depression we may need something a little bit more adaptive or a little bit more patient-centered in terms of the trial designs. So in conclusion, surgery for depression is performed worldwide using both lesional and stimulatory techniques. Regarding deep brain stimulation, which we've primarily addressed in this chapter, there's multiple targets that have been employed. The most common being the ventral capsule and the ventral striatum, which are very similar to the nucleus accumbens target. The subcallosal cingulate and the medial forebrain bundle are also important targets. Despite 2 negative randomized control trials, deep brain stimulation for depression is continuing to grow in popularity, and novel trial designs are being explored. Additional features are now being incorporated into DBS treatments, such as rechargeable batteries, directional stimulation, and eventually closed-loop stimulation. Thank you very much.